I am Poirtras, a researcher and a professor at Sherbrooke University in Quebec. I'm also a registered nurse by training, so I've been involved in primary care practice prior my academic journey. I am also one of the co-lead of the Paris OECD project with my colleague Sabrina Wong and Walter. So nice to be with you, everyone's today. So when we create the Paris, I've been involved in the Paris OECD project for the Quebec province, where I was really aware about the fact that I want those results meaningful for primary care practice, primary care provider, and patient. So when we had the opportunity to launch and to collect data in Quebec province first, when we recruit the data, the practice, and when we talk with the healthcare provider in primary care practice, we create a project which we were able to share and to present the PROMs and PREMS data come from Paris OECD project in Canada. And what we want at this time when we're beginning the Paris project is to share those data, and we want those data useful for primary care provider. So it is with this in mind that we create a knowledge to action intervention based on the quintuple aim to support a primary care provider experience, patient health, and patient also experience in primary care. So we create an educational intervention where we share the PROMs and PREMS data, and we talk with the healthcare professional about what PROMs and PREMS data could become good and meaningful indicator to support primary care organization and services in the practice where Paris OECD were involved. So with this in mind, this is quickly the overview of the Paris OECD project, but what we have to understand is that with Paris OECD project, the only mandate was to collect data and to share those data to the OECD organization to compare Canadian data to other country. But we want has a Quebec lead, but also all the Canadian team want those data meaningful for primary care practice. So we didn't want just to take the data and don't send it back to the primary care provider. We want to create a collaborative team and relationship with practice that they were involved in Paris OECD. And when we sell the Paris participation, we also sell the fact that we send and share the data to every practice in Quebec province, and we will work with those providers to see how those data could be routinely and used at certain period of time by a practice manager, healthcare provider, and IPT member to become a standard, so a high quality data that they can use to support that are primary care organization. This is quickly the framework and the background that shape our methodology, but we are also implementation scientists and KT. We have a big KT interest, so we create this project to be to engage provider and primary care practitioner in our Paris OECD survey, but also we take this opportunity to have a reflection with primary care provider about how we could integrate and implement PROMs and PREMS routinely and cyclically, in primary care practice and primary care network in Quebec province. So we create dashboard. Those are the so for the Canadian project, we have 65 practice and more than 4,000 patients. But what we in Quebec, we have around 15 practice and more than 100 patients, 1,000 patients, sorry. And we had also practice that they were francophone, but also anglophone. We developed with our Canadian colleague and provincial coordinator in each province a 4-page final template where we share the same indicator and the same PROMs and PREMS data. So it was a first cycle of template because Paris OECD has a lot of data that can be present to primary care provider and practice, but we choose together what could be the first domain and subdomain of PREMS and PROMs that we could present. First, we create the dashboard, and after this, we create also the virtual or in-person learning session. So first of all, we create a scientific committee to create the PowerPoint, but also all the reflexive activity that we want to do with the primary care provider. We also get an accredited learning session from the Sherbrooke University, so family physician can have, and other IPT member can have credit B, for continuous education activity. So it will be really, really interesting for primary care provider to engage in those discussion sessions, but because they know that they will get credited for those discussions with the research team. And after this, we also give to each a provider, but also primary care practice manager, a hard copy, a paper copy of the dashboard, but also short report of our highlight and our analysis about how all our PROMs and PREMs in their primary care practice compared to other Quebec provincial practice, but also compared to other Canadian data that we have during the Paris OECD project. You have on this slide the presentation plan, but first of all, we present the meeting objective. We also do an introduction about what are PREMs, what are PROMs, and an interesting fact is that in Quebec province, PREMs do not refer to patient-reported experience measure, but most of the affectation of family physician do. So this is an acronym that the Provincial College of Family Physicians use to give some position job to family physicians. So when we start to work with primary care provider and family physician more particularly, and we talk about PREMs, we have a semantic and we have a language barrier in terms of PREMs, so we have to educate a little bit about what PREMs are in terms of patient experience. After this, we also present the Paris study summary, the timeline, and how the thing that we have done to have to get our sampling clinic level, practice level, and how the data collection process. After this, we present the dashboard, and we have some discussion about the relevance and the perceived relevance and how those PROMs and PREMs data that we present during the in-person or virtual session are meaningful and useful to support primary care organization. We test the both situation. So we do virtual learning session, but we also did in-person learning session, and both are positively well received. But I personally prefer in-person learning session, as we can see the nonverbal behavior of the IPT member, and we can have more in-depth discussion regards our result. We also found that the in-person session support better engagement during discussion, but also engagement regards PROMs and PREMs integration, because we observe that the pre-meeting discussion and the after-meeting discussion could lead to other research or quality improvement opportunity in collaboration with our research team. So it's really, really positive to just take the car and go meet the interprofessional team member or primary care provider in practice meeting. So this is an example of the dashboard for the Quebec province. So first of all, we explain what is the dashboard, but also the limitation and the strength of those dashboards. So we present descriptive data. We also mentioned to the audience that there is some limitation in terms of sampling, number of participants, and that the way that people can take those results as cash, may I say. After this, the second part of the first page is all the enrollment and response rates for Canada, but also for the province. And every practice is the darkest blue color, so they can see how they situate themselves compared to other clinic or other province. After this, we have the description of the sampling in terms of general information. We try to be similar to every practice, but we were able also to highlight some specificities. Sorry, depend on the practice, if they are rural, suburban, if they are also what is the average age of the participant in their sampling. When we met the primary care practitioner, we see that people are really interested to see if the characteristic of the sampling is similar to the characteristics of the patient that they see in their clinic. Sometimes the characteristics were similar, sometimes they were not. What is really, really interesting is that it's not important for the quality improvement discussion if the characteristic is not similar, because we have some question to ask to practitioner about if this sampling is not similar that the patient that you are seeing in your daily professional life. What is the difference? How do you could use those results and transfer this to the patient that you represent and the patient that you see in your clinic, in your clinical practice. After the characteristic of the sampling, we were interested to present the PREMS, so the experience of care and the health outcome. Mainly, we focus on this first session because, as I previously said, Paris OECD project has a lot of data and indicator that we can present, but mainly we focus on discussion about the time of the consultation, how patients were involved in the decision that they have to take. So we refer to shared decision making. We were also interested about the patient-centered care perspective, about to be considered as a whole person, but instead of a chronic of a disease only. We were also interested about the relevance of the appointment of care. So did I see the family physician today, tomorrow, in a week, or in a few weeks after my needs? And for the health outcome measures, so the PROM, we were interested about the general health, about the pain, about emotional distress, about management of health and well-being, and about the quality of life overall. What we observed when we also present those data to healthcare professional and family practice manager is that results are really positive, and people are really happy to see that most of the patients that they've seen in their clinic positively rate care experience and their health outcome. But 2 points. We observed that family physician and interdisciplinary team member are really interested about the opportunity of improvement, so that they are really interested to know what are the characteristics of the patient that they don't perceive their health as positive. What are the patients that they don't experience positive health experience? So they were really interested about the dark blue line, and they're asking us for more statistical analysis to be able to have more detail about who are those patients, because what they want is to be able to transfer those data and evidence come from Paris OECD to the characteristic of the patient that they are seeing in their daily practice. We were also surprised to see that there is some difference between, as an example, about the overall quality of life, of the overall perceived health status, that people mentioned that they are, family physician mentioned that they perceive probably the patient most sick than the patient see in himself. And so we talk a lot about this. We talk a lot also about the sampling characteristic, and they will possibly also bias in terms of number of patients that they answer the questionnaire in clinic, but they were really interested about to see the discrepancy between their perceived their perception about the health of their patient and the way their patients perceive their health condition. Finally, during the discussion, we also do a lot of prioritization and discussion about which is the data that is most important for your healthcare organization. What data could be really useful for your own professional practice? What is the data that could support quality improvement opportunity? We also use in some practice and in some in-person or virtual meeting a prioritization matrix where we use the result to identify the opportunity to improve primary care services. And we also have discussion with healthcare professionals and team and attendees about what are the things that they have to do to improve these indicators or to maintain, because as the PROMS and PREMS data present in Paris are really positive, we also use those data to talk with primary care provider about what are the good things that they are doing in their primary care practice and what things they have to do to maintain those excellent standard in their practice. And the way we question in the attendees, we also bring them the importance of in the situation there is professional worker movement. When we have workforce problem in primary care, we have to identify in our primary care practice what's work well and what we have to maintain. And this will help provider and primary care manager to support the arrival of new worker in the clinic or new family physician or student, to be sure that the high quality standard that they have already in their clinic is maintained over the time. So we do a post evaluation of our in-person or virtual meeting, and most of the time, the majority of the attendees highly value the activity, the quality improvement activity. Also highly value the way that we share PROMS and PREMS, and they find PROMS and PREMS really useful and good data sources to orient care organization. We don't pretend here that PROMS and PREMS are the only data sources that could be used to support healthcare organization in a primary care practice. But what we want to is that we believe that PROMS and PREMS have to be had to other health data sources to support primary care organization, because it gives another side of the box to take better decision and to be sure that we hear patient voice in our healthcare organization and transformation. So this is an overview. So most of the 90% of people agree that PROMS and PREMS are meaningful and valuable indicator, and majority 9 people on 10 people plan to change and to commit to do change in their daily practice or at the clinic level based on PROMS and PREMS that we share during the in-person or virtual meeting. Mainly dashboard are appreciated by provider and clinic manager. Attendees to our activity find that PREMS and PREMS is useful data sources to have reflection about what is valuable for patient and what is the gap between primary care perception and patient perception. They also find useful the way that it was the first time that they have feedback in terms of care experience. And at the beginning of the Paris OECD project, a lot of practitioners were afraid about the PREMS scores. So because they were afraid about what can I do if the patient doesn't find that the clinic works well, if the patient find that I'm not patient-centered, or if the communication is not good. So people were afraid to do not have leverage to improve patient experience regards the results. So in fact, we observed the inverse. So PREMS is mostly positive in most of the primary care practice in Quebec, but also in Paris OECD in Canada. But there is some space for improvement, and this is what practitioners find really, really relevant. So thank you. I hope you enjoy my presentation. I will be really interested to discuss and have more discussion with you. Thanks.